there. I'm Jaya Chandrasekhar. I'm an interventional cardiologist in clinical trials research. And it's an honor to speak with Dr. Tomas Andersson today. Dr. Andersson, do you want to say hello to our audience?
Hello, I'm Tomas Andersson. I work at AstraZeneca. I'm the VP, the Vice President Clinical for Cardiovascular and CKD.
Thank you. Thanks very much for your time today. So the main thing that I really wanted to talk to you about today was the HOPE-3 trial, which was presented at ACC 16 yesterday. And what was very impressive was the way the study was conducted as a collaboration between industry as well as CIHR for this investigator-initiated study. So it was a big study, 228 sites across 21 countries. And as we all know, clinical trials, can be an expensive affair, can go on for a very long time. There's burdens of regulatory control, site onboarding, and then keeping the trial afloat so that we can actually see some results. So what are your comments on such a collaboration between public and private? And really your perspectives based around HOPE-3 and other trials that you might have seen?
Well, let me start with HOPE-3 yesterday. I was there and looked at it, and actually for me it was great to see the results because I hadn't seen them before. One of my co-workers has been working with it, but for me it was fantastic data. HOPE-3 it's an unusual collaboration in the sense that it's so big. It's been going on for a number of years and cost a considerable amount of money. However, it's the kind of study that probably would have been hard for us to do. I think it was through Dr. Yusuf made possible. We are supporting external studies quite frequently, right. But it's quite unusual that they are
such a scale.
On this scale. Absolutely. But I felt tremendously proud for the advancement of our knowledge and our treatment when I saw the data yesterday. It was great.
Exactly. I mean, this is, patients without cardiovascular disease and risk factors, not titrating it to repeated measurements, et cetera, et cetera. So, it's a great accomplishment.
It was, and I think you heard from the, at stage all the comments and in media. I saw it on NBC News this morning as well.
Right, so lots of enthusiasm. So what do you think about CVCT and, how does the CVCT model work for a private-public collaboration in the same way? And, what can clinical trialists or aspiring clinical trialists aim for in trying to kind of get with this model, if you like?
Well, CVCT, I think, is a unique forum. I've been participating a few years, and I appreciate it a lot. I think the focus on therapy, trials, and the science, and the mix of academia, industry, regulatory agencies, it's quite unique. And the discussions are, I think, very worthwhile ideas come up.
Right,
I mean, it's really focusing on the most burning topics. So I would hate to miss it. I'm definitely come back this year as well.
Fantastic. Yeah, I think, with collaborations like this, we try and take away the impediments in seeing through clinical trials and actually making sure there's, meaningful discoveries that we can use for patients and people. So I think that was great. I'm going to switch tack now.
Okay.
So let's go to Accelerate, which was presented today. So if you could tell us your thoughts about Accelerate or the interpretation of the results. And as we know, the trial was terminated early for futility. So, some remarks around that would be wonderful.
I was there and looked at the presentation, and I must say it's, as always, when such a large and long study comes out negative or neutral, it's a pity. It's a lost opportunity for improvement of therapy. At the same time, it's well conducted, it's conclusive, it seems to answer a question in a very effective way. And I'm fascinated by the results. Look at 40% reduction in LDL and 130% increase in HDL. It looks fantastic.
Unheard of, yeah.
It's extremely effective
Right.
in affecting the lipids, and then absolutely nothing on efficacy. I mean, to me, it tells me three important things. Lowering LDL is not the same, independent of mechanism.
Of course.
If we think that increasing HDL will bring a clinical benefit, it needs to be done through another mechanism than CETP inhibition. And finally, of course, you need to do the large outcome studies to get the answer.
Yeah, it's all about the design of the study in conjunction with mechanism.
Yeah.
So, yeah, no, that's great. Thank you so much for your time this afternoon.
Thanks a lot, Jaya.
Thank you. Enjoy the rest of ACC.